Very good afternoon. It's my great pleasure to share with you what TuSense is developing to make pneumonia patients' lives better. Pneumonia is a lung infection. So every year, 450 million people are affected with a mortality rate of 3 million per year. So every year, 3 million people are dying because of pneumonia, which is approximately half of the population of Singapore. Bacteria causes about 55% of infection. And what is the exact problem? The treatment within the first few valuable days is not very effective because inefficient sampling. The specimen collected is not very efficient. Also, the long turnaround time. The time taken for the analysis downstream is very longer. Because of these two reasons, the pathogen is unknown to the clinician, so clinicians are forced to use empirical antibiotic, which is general antibiotic. So it is not very effective in the first place. Secondly, it gives side effects as well. This is one of the current clinical procedure, which is bronchoalveolar lavage, which is an invasive technique. So you can see a probe is inserted all the way to the end of the lung and the specimen is collected. It is too invasive in the first place, and it's a complex procedure. Also, a trained person is needed. And this procedure is used only when it is needed, not for all the for everyone. The other procedure is the sputum induction technique. This procedure, you can see this saline is nebulized into the patient and the specimen is collected, which gives discomfort to the patient in the first place. Also, the specimen collected is prone for contamination. Due to this contamination, inaccurate results and long turnaround time, because the bacteria need to be grown, and for growing it takes more than 2 days of time. So we interviewed some of the clinicians in Singapore, and we understand what is exactly needed to balance these two procedures. So what exactly needed is an invasive, non-invasive procedure, and it should not give any discomfort to the patient. Also, it should be easy to process in downstream. So when we are young, our moms have told us, when you're coughing, please close your mouth. Because it is well known, when we cough, materials are coming out, like pathogens are coming out, it spreads the disease very easily. You can see here, when someone is coughing, materials are expelled at very high speed, and pathogens, live pathogen, as well as broken fragments are coming out. And the droplets, because of the cough, with different sizes, for example, 2 micron to 200 micron. If we can collect them efficiently, it can give very good information about the pathogen which is causing the disease. So the solution is DUEC, our device. What it does in the first place, it collects very good quality specimen. The specimen collected is high quality, so no downstream more processing is required. Straight away it can be used in downstream processing. What all need to be done is very simple. This is 2x size of the actual device. The patient needs to keep close to the mouth and just cough into the device 15 or 20 times. So the collection is done. This serves two purposes. The collection is done, and it stores the specimen in a safe way. It can be transported where required. Like it can be used at home and sent to the diagnostic labs, and it can be, the pathogen which is causing disease can be identified. This is the current clinical flow. When the patient is identified having pneumonia, immediately non-specific treatment is prescribed. In the sense, the generic antibiotic is given. When the patient is not curing, the specimen is collected and then it is diagnosed. So in total, it takes about 4 days to identify what is the actual pathogen which is causing the disease. How do we change the current procedure? This procedure, once the specimen is collected, immediately it can be used, for example, PCR, and then within 9 hours of time, the same day or the next day, evidence-based treatment can start. So what is the difference? What is the difference we make here? So the procedure to collect specimen is very simple, straightforward. Just keep close to the mouth and cough into the device. Specimen collection is done. And then the time, valuable time, from 100 hours, it is reduced to 9 hours. Because in this time duration, what exactly happens, the patients, 20% of patients getting worsened. And then if you see this 20%, which is 90 million people getting worsened, and the economic burden related to that. And then we give evidence-based treatment. By using this device, patients are getting evidence-based treatment. And this can be used in non-clinical settings. Whereas the previous other techniques can be used only in clinical settings, this can be used in non-clinical settings as well. So far, I have been talking about a problem and about a solution for the problem. Now about the business. So the market, the respiratory diseases for point-of-care testing devices is 7.28 billion. And then the respiratory market is 1.5 billion. And for the collection devices alone, it is 400 million per year. And then we start with Singapore. We will be dealing directly with the hospitals and diagnostic labs. And then when we go to the overseas market, we will be using distributors. This is our estimated financial projection. This year, we are spending 165K. Next year, it is expected to grow more due to the regulatory procedures, which is 500K. And then when we start rolling out the device, we gradually see revenue flow. And this is our competitive positioning. So we compare with the existing techniques which is used in the clinic, like bronchoalveolar lavage, which is an invasive technique. And the next one is the sputum induction. So we feel this, our device gives an easy technique to collect the specimen as well as the faster results. So it is better than the current techniques. Our milestones, our key milestone is we have done a pilot clinical trial last year, and then we have our current clinical trial, which is planned in Q2 2019, followed by product validation, and we roll out in 2021. So far, we have secured 215K, which is for clinical trial and for optimization of the device, and then we are raising 500K for the various headings. This is our team. So I'll be doing the business, and we have Prof. CCN, who is helping us in designing the device and various reiteration of the device. And then we have our Prof. David Leong, who's here, who's helping us in making diagnostic techniques to adapt to our device and how to make it to various techniques, not only to restrict to one particular, instead to make all the techniques to be used. And we have our clinical lead, Dr. Vincent, who's helping us in doing all the clinical trials. And in a nutshell, why you invest in us? So we bridge a niche gap in current clinical practice, and we help clinicians for targeted treatment, and we have a highly interdisciplinary team, and we roll out very soon in 2021 Q2, and it's a globally scalable business. Thank you.
Thank you, Team TuSense. In the interest of time, we have time for about 3 questions. Any questions from the floor?
Thank you for presenting your technology. So I see that where you have compared the timeline, you have shown that the bacteria need to be grown, and then it delays because it takes 2 days. Rather, in your technology, just you directly go to PCR stage. But I have recently seen this one technology in which they, with the thread, they put some capsule inside which swells and the surface area increases so that you can collect more pathogen. And then if that is your competing technology, they also wouldn't need to grow the bacteria and they can directly go to PCR stage. So have you considered that as competition?
Okay, thank you for the question. Actually, that is invasive, considered invasive. So we need to put something inside the mouth to the lung and then collect the specimen in the very first place. But whereas our device, nothing need to be done. Just keep close to the mouth and just cough into the device. So that's the major difference between these two techniques.
I wouldn't call it as really invasive because it doesn't hurt to like insert something, just a thread is hanging. So like that we have other insertable devices also, like that in uterine devices like copper T that also exist. So they are also called non-invasive devices only.
Yeah, I agree. Non-invasive because it's not puncturing any tissue, but anything that goes into the airways is what we consider invasive because if you consider if you are swimming and any drop of water from a swimming pool goes into the airways, you choke and you cough. So this is very highly reactive environment. So putting something like that, I believe is still, I agree with Suresh that it's still considered invasive because you are going into an area where the body naturally repels things out. So we are trying to go it the other way around, where we're going to collect things that comes out naturally. I mean, anybody with pneumonia will be coughing anyway. So this is, instead of coughing to other people, we're coughing to something that we can detect.
Okay. Thank you.
Thank you.
And is it also the case that your airways are already way too sensitive, so it's difficult for you to swallow and take the whole thing out? Is that right?
Not really. So it's sensitive. The body is already trying to expectorate the sputum.
Correct,
It's
yes.
going the other way direction. I agree. So you put something in the other way, it'll just come out. Yeah.
Any more questions?
Two questions. One question is directed to the doctor. I understand you're going through the clinical trial, and I believe you embarked this project because you are very confident that you're able to diagnose faster and better. Right?
So we did a small-scale trial last year where we collected a sample from a patient with actually proven pneumonia on a chest X-ray. We did compare three things using this device at the initial prototype on a cough, on exhaled breath, and on another device which was actually collecting volatile organic compounds. That device didn't show any material. The one that collected breath was 2,000 times less material compared to the cough that we collected from when we discovered through a Western blot technique that had the protein from that bacteria. So I believe that this is far more specific in terms of the identifying the potential cause of the bacteria in a pneumonia patient.
So my next question is, if this kind of test is successful, so does your business plan includes building a more integrated system in terms of the software, the AI, or
Yes.
because
So-
you're collecting a lot of sample?
Yes. So as Suresh has
And
mentioned, it's not just in a hospital setting. We're looking at expanding towards GP, towards rural areas where they have no access, immediate access to the hospital environment with diagnostic tests and everything. So that could be an extension where we have a buffer solution to collect and store it, or we transport it to areas where we can diagnose.
Cost-wise, how much cheaper is this compared to the
I let the
existing
business
approach?
person handle this.
So we estimate this to be $10, close to $10, conservative estimate. But we will price it close to the sputum induction. We would not charge too much. We will charge it close to a sputum induction, which is charged close to $80 in Singapore. So it will be equal to sputum induction.
Thank you. I believe we are out of time for questions. They have a booth outside to demonstrate their prototype, and of those of you who love coughing can go to them and cough all you want.
Thank you.
All right. They would love to collect your cough. Okay. So, okay. Thank you, team. Thank you, team TuSense.